Hello, is this thing on?
Do you think they can hear us?
Nah, let's say it again. Hi, and welcome to the Gritty Nurse Podcast, an unfiltered discussion related to health and healthcare. My name is Amie,
And my name is Sara.
and we are your podcast hosts.
If you're listening on Apple Podcasts, Spotify, Google, iHeartRadio, Amazon, or any other podcast listening platform, don't forget to subscribe so you can get updates to when we have our latest episodes. Also, don't forget to rate and review us.
And if you like what you're hearing and you love our advocacy work, don't forget to go to www.grittynurse.com and click on the donate button.
As little as $1 or $2 a month for a total of $12 a year will help us with our monthly podcast costs, such as website hosting, our hosting platform,
audio equipment, and the time and energy it takes us to put out good quality episodes. We thank you and we appreciate you. We have had quite the weekend. It's been super stressful, but I'm hoping today that we could bring you something that will continue to lift your spirits, that will really help you have a different insight and a better insight in how we can connect with our patients on a different level. So I'm really pleased and super excited to introduce our guest, but actually I'm going to get Sara to introduce our guest for us today.
We have a really unique guest today. Her name is Sue Robbins. She is a published author of a book called Bird's Eye View: Stories of a Life Lived in Healthcare, which was published in October of 2019 and was launched at the Gathering of Kindness in Australia. She is the mom of 3, and her youngest son has Down syndrome. In 2017, Sue became a breast cancer patient. Sue's writing has been published in the New York Times, the Globe and Mail, and the Canadian Medical Association Journal. She is a seasoned speaker on patient and family-centered care topics. She has also worked in paid family engagement positions at the Stollery Children's Hospital and Sunny Hill Health Care for Children. So welcome, Sue. We are so glad to have you here today.
I am very excited to be here. And thank you for asking me, a patient, onto your show. I think that's like totally revolutionary, right?
Well, you know what? We should probably have more patients on our show, to be honest, because I think just from learning about you it's actually very interesting how we met. Actually, I think someone was being quite rude to you online, or you had actually a really bad day, and I was just like, "Hey, you know what? Screw that person. You're awesome." And patients have so much good insight into what care really should look like. I think we need to move away from a didactic model or a paternalistic model of medicine where we as nurses, physicians, allied health are dictating what care should look like, and really, really listen to the patient's voice. So I'm super, super excited to have you here today, Sue.
Yeah, and I just want to add, Sue, that Amie and I both read your book, and I think you are such a talented writer and you're so articulate with a lot of the examples that you give. But I don't want to give everything away to our listeners. So maybe you could just tell us a bit about your backstory and why you wrote Bird's Eye View.
So it's actually interesting talking to nurses because I feel a bit shameful because I'm actually a dropout nursing student. So
Oh,
I
you're not a
way back, a long time ago. I don't want to tell you how long ago it was. I finished 2 years of a 4-year program. So my family always likes to kid with me. I'm like half a nurse, right? So if somebody like cuts themselves or something, I might kind of know what to do, but that's as far as I actually got in nursing school. So that was my first exposure to healthcare. And then really I got re-immersed. I worked in healthcare admin for a long time with the Department of Health and in these government cubicle positions in, funding and costing and things like that, which is actually an interesting perspective to also have. But I really got re-immersed back into healthcare when my youngest son, Aaron, was born 17 years ago with Down syndrome. And a lot of people in the general public don't understand, but Down syndrome is not just an intellectual disability. There's lots of health issues that go along with it, especially when kids are younger. So,
Mhm.
we went to a million appointments and just the way he was diagnosed, and there was a whole bunch of elements in the healthcare system with him. Um, And then we kind of moved to the education system. We started going to school and I started focusing on advocacy for that. But then 4 years ago, I got diagnosed with breast cancer. And I
Yeah.
remember, people saying, "Oh, now you'll get your own patient perspective in healthcare," and I'm like, "Well, I actually wouldn't wish to cancer on somebody so they could have a
Yeah,
patient
geez.
perspective, right?" But I did find it was different not being a caregiver. It actually, being sick myself, it was a
Right.
totally different experience, and I can talk about that a little bit. But I had all this like various what I call my book bird's eye view because well, my last name is Robbins, Robins, so there's kind of a a bird thing that goes along with having a last name Robbins. But
Yes.
just looking at healthcare from like a broader perspective has been like super interesting. And because I was a writer before, I really believe in stories and storytelling. So I thought I would write a book of my family and patient experience in healthcare. That's pretty much what Bird's Eye View is all about.
Yeah, and I mean, it's I'm so glad that I took the opportunity to read it because I had so many aha moments, and I'm sure Sarah had them as well, where it was just kinda like, "Oh, I didn't actually even think about it that way," or, "Wow, that physician said that," and maybe they didn't really even think about how that would be perceived to the person who's, like, on the other end, right? And I mean, I think your book lends such an important perspective, but maybe you can tell me a little bit about what does patient and family-centered care mean to you? I know that's a really big question, but even just talking a little bit about your book, could you kind of tell us just a little bit about what does it look like from your perspective, from the patient perspective?
Sure. And I mean, I can give you the rote answer that it means respect and dignity and information sharing and partnership. Like that's what you'd read in the textbooks. That's what patient and family centered care means. And it's so funny because the term is almost gone, it's not in vogue anymore. Like people talk more about patient experience and
Yes.
patient engagement, and those are two different things. But basically, I mean, and it's funny because I have a friend, he's a neonatologist, and he didn't like the term patient family centered care. He prefers the term relationship centered care. And I
Wow.
actually agree with that. And I'm hoping that that's what my book kind of got across is that, really healthcare is about all of us as human beings. And the best kind of healthcare interactions are, when I know you as my nurse and you know me as the patient, but we connect as humans. We don't, and I have lots of stories about that. I hope in my book that talks about the importance of like chit chat and getting to know each other, and
Yeah.
letting me see your heart a little bit, and how those connections are so strong. And I hope my book is about humanity and healthcare for everybody. Um, and as I said, allowing people peek into your heart so that we know that you care about us. I think that part is really important for patients. And I worry sometimes health professionals, they hide behind professionalism and we never really get to see them as human beings. I'm not saying I want to be your friend on Facebook, right? Like I'm not talking about
Right,
that
right.
type of thing. I'm even talking about, figuring out if we have one thing in common and making a connection that way, and how powerful that when that happens, especially because us patients present to you as so vulnerable and fragile, that really I think that helps, that whole kindness and compassion thing really is what helps start us to heal.
Absolutely. And I think one of the things that you get across in your book, and I've experienced myself as well, is it doesn't necessarily take longer to make that connection or show that you care, right? We're not asking you to spend an hour talking to a patient. It's more about how you talk to them and what you say that really makes a difference, I think. And it can really it can be something that they carry with them for years to come. Because I remember this part in your book where you talked about a pediatrician that was really kind to you at the beginning when
Mhm.
you first found out your son had Down syndrome, and what a difference it made with her approach that she had with you. So I think it's really important that healthcare providers realize that they do have a big impact on patients and their families.
We remember actually, the kindnesses. I try to forget about the not so good stuff, but the kindnesses stick with us. And that story I wrote, it was about Dr. Darwish. She was
Yes.
Aaron's pediatrician, and she, just the things she did was she, when she came into the clinic room when we first met her, and Aaron was only 2 weeks old, she scooped him up out of his car seat and she held him. And just
Mhm.
the act of doing that was such a powerful thing, because he'd been to a bunch of specialists checking him out and his audiology and cardiology and all that kind of stuff. And she was the only one who actually did that, that didn't treat him like he was some specimen, right? That they
Right.
were examining. And how, I'll just never forget that image of her, standing by her door. And she's always very well dressed, Dr. Darwish. And I think I remember what she was wearing. Like, it just imprinted on me in such a positive way. And I say that she helped our family, in a time that was very, very dark for us. It put us on a place of strength so that we could go forward, as opposed to devastating us and having us, feel even worse. Like, she said the first words out of her mouth were, "You have a beautiful baby boy." That's what she said.
Yeah. Oh
And
Mhm.
good.
anyone can do that. Like, someone who's a receptionist can do that. Like, anyone who works in a healthcare setting is able to do that, and to look at Aaron as a human first, as opposed to a bunch of problems, was like such a powerful thing for us.
Yeah, like I totally can empathize with you because like my son who has autism, so he's actually a twin. And I can remember seeing the drastic difference between the people who saw him as, this being, this person with so much life, so much character, so much more than a diagnosis, than those who literally treated him like he was just like the next, like this is just the next thing. We're gonna just look at X, Y, and Z, and like they didn't really interact with him or treat him with that dignity. So I think you hit the nail right on the head in terms of making sure the connection doesn't have to be long, like Sarah was saying, but the connection has to be genuine. That you feel that this person really does see you as a human and treats you that way as well.
Great. And Sarah, what you said, it's interesting, because I had a chance to launch my book in Australia, which seems like ludicrous right now, because we're all living in the pandemic. Like, we live in Burnaby, like we don't even cross boundary to go to Vancouver, right? Like, we just we're so close to home. But anyways, in the olden days when you were able to do that, we were in Australia, and I did a grand rounds for a bunch of physicians and residents and medical students in Tasmania, of all places. And I was giving my examples of, Dr. Darwish, and stories about how, that connection, how important it is. And sure enough, and this happens in almost every single one of my talks, in the question and answer part, a physician got up and said, "Well, we don't have time to do that. We don't have time." And so what I basically did, because I was prepped for it. I don't talk in terms of research, and that's not really my thing. I only talk in stories. But there's books about compassion, right? And there's studies about compassion, and there's research that says it does not take more time. Like, it might take 30 seconds. That's what they say,
Right.
to recognize. It's from a book called Compassionomics. I was just trying to remember what it was called, Compassionomics. And they aggregated all the research about compassion in healthcare settings, and that's what they figured. It took just over 30 seconds. And basically, it's just to validate people and to listen to them about what they're saying. And what I think people worry about, they think it's some Pandora's box, right? And if you ask me how I'm really doing, like, suddenly you're going to have a 2-hour therapy session. And
Right,
maybe
right.
that's not
Mhm.
your job,
Yeah.
that's a mental health job. Oh my God, how do I get rid of this woman and refer her out? But that typically doesn't happen.
Yeah, I think that's really important. And even in this sort of times that we're going through, I think it's important to have genuine connections, and patients can sense that. They can sense when someone's being genuine versus hiding behind their computer or just treating you like another number. I'm just wondering what you are thinking about in terms of staff well-being. How do you feel that this affects patient well-being just in all your experiences with the healthcare system?
Yeah, that's an interesting question, because I've changed, I think, the way I've thought over the years. So I first worked in a paid position in family engagement at the Stollery Children's Hospital in Edmonton, and really what I worked on was bringing families in to, give talks at nursing orientation and grand rounds, and there was a council, and it was kind of a classic setup that way, but it was very much family centered care focused. So much so that at the beginning we forgot about the children and youth. Like, we were really focused on the family's experience, like
Yeah.
the mom and dad or guardian, or like, and we didn't consider, we said patients are part of a family, but really that, and now they've opened it up, and now they have a youth council, and certainly they've done a much better job. But at the beginning, we were really only thinking about this family centered care business. But then
Right.
when I moved to Vancouver to take a job at BC Children's Hospital at their pediatric rehab center, and what I realized when I first started working there, I was the family engagement advisor, and I think some of the staff didn't really like the idea of even having me hired because they felt they did family engagement totally well. And like, why do
Right.
we need somebody here to advise us on that? And so I realized with them that's because I work closely with the staff, is that they need a chance to tell their stories too. And we
Mm.
talked a lot about reflective practice. And I tried to bring in Schwartz rounds, but it didn't end up happening. Which is a reflective practice kind of session that people can do
Mhm,
regularly
mhm.
when hard things happen. And so we had things like we started a book club, and we read a couple of books about kids who would need rehab services, like Boy in the Moon by Ian Brown, and we read The Spirit Catches You and You Fall Down.
Oh, I love
Uh,
that
I
book.
know, by Anne Fredman, which is a wonderful book, and
Oh
I
my
wrote
gosh, that
it.
book makes me cry all the
I
time.
know. It's like, so it's, and what those books really do, I think, I love the idea of using the humanities. So the staff read the book, we read the book together, but then when we had our book club, I had also invited families to read it too. So we
Mm,
had the book club together, which was so great
that's
because the
amazing.
families could give their perspective and the staff gave their perspective. And then I think afterwards, and I'm making an assumption here, I didn't do a bunch of research on it, but I could see the connections in the room, right?
Right.
And I think they realized, the families realized the staff were like human beings, and the staff realized the families were human beings. And what the books did was like kind of break down that whole stuff down. And we did the same thing with TED Talks too. Have TED Talks and then talk about them afterwards, kind of as
Mhm.
reflection. And that was really powerful too. So I think it made me realize that staff need to have a chance to share their stories too. It's not just only about the patients all the time.
Well, I kind of want to like dig into that a little bit because let me kind of tell you my perspective. So let's say, so most of our listeners are probably nurses, physicians, allied health, right? So when I think when this type of information started first coming to me about patient engagement networks was sometime around maybe about 3 or 4 years ago during accreditation. So I remember all of a sudden it was like, oh, we need to have patient and family engagement right now. And we're like, what is that? And like nobody knew what it was. And then all of a sudden it was just like, well, with all our policies, we need to have a patient family advisor. And it just seemed like it was another box that we had to check.
Mm-hmm.
So when you think about buy-in from frontline staff, from nursing leaders or managers or CEOs, it shouldn't be about, like we need to do this, we need to check the box. It really should be about the value that patients actually bring to healthcare. And it took me, it was kind of weird because it was kind of like people almost saw it, and I'm just going to be generally honest. People saw it as like an inconvenience. Like, why do we need to have this extra person here telling us how we already know what we need to do? And full stop, no, we don't. We don't have all the answers, and the answers do lie with patients. And it only took me like so long to kind of say, oh my gosh, this is actually a model that makes a lot of sense. Why weren't we doing this before? But I think the cell has to be completely different. I think the way it's languaged from a healthcare perspective should be different. And I think that people like you should be coming in and saying, this is what I do, and this is how I can help. This is how you can see change. Because I think also with nursing and healthcare, we want to see something very tangible. And if we can't see that it's something that might change results, then we're kind of like, no, we've been doing this for how many years? Why should we change now? But I
Mm-hmm.
think there's so much value to patient voice.
Yeah, and just to
Yeah.
add to that, it's really important that when you do have a patient at the table, that again, they're not there to check a box. Like you really need to listen to what they have to say, right? Versus having them there just for the sake of having them there. They're there to help you co-create. They're there to help you make changes and give different perspectives. And if you don't agree with that, that's okay. But it's important, to have more voices at the table.
I mean, engagement is something. I bet when I started, that was like 15 years ago. So I've really seen it change over the years. And tokenism is a huge thing. And the other, well, one of the biggest problems with this, and I can say this because I am like, a white middle class, uh, middle aged woman. And typically you will get me sitting around the table. That's what ends up happening when they start doing
Mm,
the engagement thing, or it's somebody, who that can work from home, and so they've got flexibility and they're not working full time. And so what I've been a bit distraught about, it's kind of ended there, I find, and that they really haven't made the effort to outreach beyond someone like me who's comfortable in a boardroom or standing behind a podium. And like I and people sometimes show up and say they speak on behalf of all patients, which I think
it's
is
not, yeah.
total bull. Can I swear on the show? Like,
Yes, you can.
Yes,
okay, it's
yes.
like total bullshit, and there's a lot of ego involved with it, and because us patients, like, or families, I mean, I'm still like yelling into the wind, right? Like looking for some, especially because I have a disabled kid, right? And he's been totally forgotten in the pandemic, and so for
Yeah.
someone to say, "Here's a microphone," you're kind of like, "Holy, somebody actually wants to listen to what I say." But the problem is, we hang on to that microphone, and we're not necessarily willing to give it to somebody else who, I mean, one of the really smart things I heard about engagement once is that the people who are sitting around the table, whether it's metaphorically or not, right, it
Mhm.
should represent the people sitting in your waiting room. And if they're
Right.
not, you've done something wrong. And I got to see that I'm giving my second book away that I'm supposed to be working on, but I have no emotional bandwidth to do anything other than open the file and then close it again.
Oh god.
It is about this whole partnership thing. But so my first book, like Bird's Eye View, I tried to write about at point of care, like that. So there's two. I think there's two different kinds of engagement. There's one when we're actually, people say bedside, but it's not always at the bed, right? So at point of care, when you're there as a patient or family member, and how are we engaged that way, and how do people ask for our feedback, and how are we treated? And so Bird's Eye View is a lot about that. But then there's also the organizational engagement piece, like you were talking about, Sarah, like about the boardroom or having a council or whatever. And so they're connected, but they're kind of two different things. And I think we have to start with the point of care. To me, that's the most important. And the one thing I worked with at my second children's hospital a lot on before I had to leave, because for complicated reasons, plus I got cancer, was
Yeah.
was about the whole, I'm putting this in quotes, you can't see me because it's a podcast, but the complaint process, which I makes me like blah, because it's not about complaints, it's about like constructive feedback so you can be better, and
Right.
how I can help you be better. Like I wish that's how we could do the reframing for staff, is that, saying that actually, like, we can help you, like, we if we do this together, because we all want the same thing in the end, we can help you. But there's such reluctance, right, to have patients as true partners. It makes me, I'm a bit jaded about the whole thing. I've been
No.
used as a token, like trotted into the boardroom to
Yeah.
tell my story. And I'm just like, I'm a bit done with it.
You could
I
tell
think
that it's falling on, like, deaf ears. It's just like, "Oh, we did it. Check the box.
it's
Yay."
pretty easy to figure that out once you've done it for a long time. So
Yeah.
yeah, that piece, it's an interesting topic. I'm not saying don't do it, but I'm saying I think we have to try a little bit harder and not just do low hanging fruit. Like, and I got lots of stories about engaging folks that aren't like me, right? At the children's hospital, and you know how you do it? You do it by outreach. That's what you do it. You go to people. And I did so much of my work at coffee shops. I met people in their apartments. I met them for lunch. I took them out for lunch, right? Like, that's how you do it. You don't like sit in your boardroom and tell people to show up to a meeting.
Mhm,
So I feel
mhm.
like you've hit on a couple really good things. So one, meeting people where they are. Do we have to wait till someone's sick before we decide to have patient engagement with them? I don't think so. I think that's a brilliant idea. That type of outreach, that type of like, you want to know who is in your community. So why not go out to your community and talk to them before they're ill? Like, I think that is a perfectly rational thing to do. And the thing is, why hasn't that been thought about here? Like, I think that's a great idea. And the other piece that I feel that you touched on, that I was kind of like, I was smiling and nodding here in the background, is you touched on a piece where you said, you know what, you are a middle aged white female. We need to look at adding other voices to to make sure it's representative. And I love that. Like I'm here for that all day. Not saying that white women don't have something to say, because obviously they have something to say as well. But really understanding, what does that representation look like? How do we bring other people to the table where we understand that there's disparities and there's different health outcomes? So people with disability, people who are marginalized in society, people who are people of color, indigenous, black folk. Like I think it's so important to see these people sitting at the table, and not just sitting, being able to have that voice and to speak, and then for us to actually do something about it. Because yes, we get invited, we might get the seat, we might get the microphone, but sometimes they really aren't listening. It's another checkbox. So I really like the fact that you said it needs to be representative of the people in the community, and I'm so glad that you said that. So yay.
Yeah, I get sick of listening to myself and people like me. Like, I mean, I'm not saying I don't have a story. Obviously, I think I
Right.
have a story. I wrote a whole book about it, right? Like, so yeah, so there is, but it's not that you can't just end there. You can't just
Yeah.
end with people like me because, like I said, it needs to look like your waiting room. That's what representation is the people who are actually using your hospital, your health facility. And sometimes it's a matter of the most powerful work I've been involved with is when we forget about being invited to the table. We just build our own goddamn table, right? Like we're just like, forget it. We're going to do stuff ourselves in the community. And you guys want to catch up later, then you can go ahead and do it. But like I said, I'm not doing that right now. I get, there's all these hills you can die on. And the
Yes.
COVID is right, really just don't have the we're just trying to survive. I think
Yep.
everyone's just trying to survive right now. But my job, because I have a disabled kid, is to make sure that he has the space to
Mhm.
communicate for himself, whether it's in the advocacy arena, which he has been doing a little bit. Hopefully I'm not pushing him like a stage mom, but it's always a balance there. Or even a point of care, like for instance, when he goes in to the doctor, we go in together. Aaron's 17 now, and
Mhm.
he has Down syndrome, and he's a pretty talkative guy, like, so he communicates verbally.
Right.
And I'll say to the doctor, okay, this is why I think we're here, and give whatever reason. And then I get up and leave, and Aaron and the doctor have time by themselves for him to talk to her without his mother hovering over him all the time. So
Right.
I
Right.
think that kind of thing can be modeled both at point of care and and in the kind of broader advocacy picture too. But people with intellectual disabilities, I mean, they get totally overlooked. Like that's the
Yeah.
last stance, thinking that, and just people not being patient to listen. It's all only
Right.
about listening. And you said to do action, not just listening. Like I don't need a bunch of head nodding. I want you to actually do something.
You're darn right. It's just like I'm not here. It's not just a pretty face sitting at this table. I'm here to
Mhm.
tell you what things that you could do to improve how you deliver care in your community. I totally love that. So I think I have the last question here. So, but of course, we can keep talking because there's lots of things I have that I want to bring out here. But how can we be better at patient engagement and understanding patient voice? So if I think about even some of my own examples. So in healthcare, everything for the most part is really fast paced. Like I've never seen like a slow paced healthcare day. Like even on some of the days where we would use the keyword, which I'm not going to use, I'm not going to be bashed by my community. But even on those days, there's still a lot going on everywhere else. And I even have been, in the situation where I'm running my tail off. I don't have that extra 5 minutes, or I feel like I don't have the extra mile, or whatever the case may be. And everyone is doing their own thing. So how can I be a better patient engagement? How can we better understand patient voice?
My answer to that is stories, stories, stories. So I think that us patients, for the most part, communicate about ourselves in stories. Like I don't talk to you and say, you know, she's, she formerly had breast cancer 4 years ago and she had a partial mastectomy. And like, I don't, that's not how I describe myself, right?
That's
Like
doctor
I
talk,
talk
right?
I know I talk about myself like in terms of my experience and what's happened and how I felt about it. And so I really believe strongly that healthcare is imbalanced, and that I believe in science. I'm getting the vaccine whenever they give it to me. Like, I just want to make sure everyone knows that. Like, I totally am I'm not a science person, but I believe in science. I have faith in science. But I think that we've gone too far the other way, and which is so great about your podcast, because I think probably people aren't going on your podcast and like spouting data and statistics, right? Like, people are actually sharing their stories. And
Yeah.
that's actually also what we have in common with healthcare professionals, because we're all human beings. We all have a story. So I would say, if someone came to me, I mean, I kind of do. I'm lucky. I do a bit of consulting in this area because I'm a freelancer, and said, "What's the first thing we can do for patient engagement?" And I would say, let's make room for stories, whether it's at bedside and it's how you do your so-called intake or assessment, or that you make the space to ask actually how people are really doing and go into the emotional and mental health part of healthcare. Like, when I was a cancer patient, like, nobody ever asked me how I was, like,
Mhm.
ever. Like, they just said, "How are you?" Fine, like that kind of Canadian thing that we all do with each other.
Yeah,
And
yeah.
the one time I said, I'm really struggling. I had some troubles with my extended family estrangement, and I was going through like a really hard time when I got my diagnosis. And she immediately referred me to a psychiatrist. Well, I didn't need to see a psychiatrist. Like, of course I'm kind of depressed. Like, I have cancer, right?
Yeah,
Like, can't we all assume that everybody that has cancer probably is got a lot of anxiety and maybe some situational depression, if nothing else, right? And so, but
absolutely.
it was like, I could tell she was like, "Get her out of my clinic. Like, I can't deal this oncologist," right? She couldn't deal with that. And even if I had had a chance to say, "This is actually how I am," really, I wouldn't have taken up 2 hours of her time. I'm
Yeah,
cognizant of her time. And so allowing me at the bedside to share a little bit about my story, but also organizationally, man, I just think it's so powerful to have family stories. And it doesn't have to be people in person presenting. Like, there's lots of stories that have been written, right, that you can share. And there's a big med humanities movement, right, like online and on Twitter, to talk about, just, I don't know, like, how it feels to be a patient. I think that part is really important. And I would start with stories. That's what I would do for engagement. And some low hanging fruit. Sorry, I'll just give one quick story. When I worked at the Children's Hospital, they had super old building, and they had pictures that have been up for 30 years of black and white pictures of therapists doing things to children.
oh
So it was
god.
like, they were doing some sort of OT or physio, or, and there are these black and white photos up on the wall. And it really reflected like a provider centered care approach, right? Because it was kind of
Right.
all about the provider. And so we had a chance, because a whole bunch of paintings had been donated to the Children's Hospital. And so I thought, why don't we switch up the painting so it reflects the people that we're serving here, right? When you walk in, it's, a beautiful, colorful painting that would appeal to children and youth, not just little kid paintings and stuff. Oh my
Right,
gosh,
right.
like, I can't even tell you. I mean, it took me 6 months to get that done. It seems pretty simple, but there was a lot of staff resistance who didn't want change. But once we finally did it, and families went and looked at the pictures and voted on what paintings they wanted and stuff, and it was actually ended up being super fun. But it was something that was tangible, that was real. And you, like you
Mhm.
said, and you could see it when you walked into, and people kind of dismissed making physical changes. But I think that it can be a really powerful thing to start with something like that, that's, easier than behavior change. Let's just put it that way.
Behavior change is definitely the hardest part of healthcare, and I like that you give this example because it seems like when you're in something or you're working somewhere for a long time, you just stop seeing everything, right? So maybe you've walked by this painting 100 times, 1,000 times, and you never thought that it could make a difference, but your patient perspective just really brought to light that it's important what you see when you first walk in, and that you maybe don't want to see these dated pictures that are providers doing things to patients versus doing things with them. So I really love that example.
It actually reminds
Mhm.
me of, do you guys watch Parks and Rec? So in Parks and Rec, they actually had like a huge painting, and it was an old town mural that they had, but it was so outdated. It was like super racist. But the thing is, they kept it there because it's tradition, it's whatever, and they're just like, no, it's about time that we actually make some changes to this because things are different now, and we need to look at things differently. And I completely understand with what you're saying. We need to be able to be flexible, to be able to move with the times, to see that, you know what? It's like Sarah said, we can't keep doing things to people. We have to do things with people. And I think that is such an important principle in terms of the whole understanding patient voice and understanding what patient engagement actually looks like.
Mhm.
And storytelling. Like, I mean, that's why we do what we do.
Mhm.
I think nurses, physicians too, allied health, I believe that the power of stories, these are some of the things that stuck with me in terms of my own learning. When I heard a patient experience story, or, there was a situation where something went wrong, and we were actually able to hear from the family from their perspective, or, just being able to sit captive. Because we actually, at an organization that Sarah and I did work at, they had Schwartz rounds and they were
Oh.
powerful.
Mhm.
And I really feel that you learn so much from hearing what the patient has to say, or what the caregiver has to say, because they are the ones who really know what needs to be done.
Yeah,
So,
and don't be afraid of us. Like I hope I'm not that scary, right? Like I'm just like regular. And I think sometimes people think, especially if I get invited to talk, they're like, "Oh my God, here comes an angry patient," right? And if you read my book, like, yeah, I had some shitty experiences, and I think my turning point when I worked at that children's hospital was I got up in front of all the staff and I had a talk that was called "I Am a Difficult Mom." That's what it was called. And so I described my son had been hospitalized with pneumonia at that same hospital earlier that year. I described like the experience of what it feels like to have your kid in the hospital. And what I say is like basically we're not at our best. We're in fact at our worst. We're at mama bear, right? Like we feel like
yep.
mama bears, and we're so protective and so stressed out. Like, and we notice every single little thing. Like basically, I feel like I'm an animal. Like I'm some kind of because I'm like
We
don't
revert back to
yeah,
our
it
animalistic
is.
selves.
Well, and then, I got this great picture that I've used on my blog before. I've shown it to med students, and it's like, it's the mom in the hospital picture. So I got a hat on because my hair isn't washed. Like I've got my yoga pants on. I'm wearing my Birkenstocks. I'm like, I probably don't have a bra on, though nobody needs to really know that. But because I sleep in my clothes at the hospital and I
Yeah.
haven't eaten, I can't leave my kid's side because he's in isolation to go down and get a coffee. Like basically, I'm a train wreck. So somebody there, I had a medical a physician teach me once when I worked at the Stolly. She said what she tells her med students is if you see anger coming out at you from a parent in particular, it's probably fear underneath. And
Right.
so I really think, and I said to the staff, I said, like, if you as a nurse had a kid in the hospital, you would be a difficult mother too. Like I guarantee you would be of all things, right? Like because if you think about what if so I think understanding how each other feels is really
Yeah.
the key to all this work, whether it's going to a boardroom or at the bedside. And I used to say, like, we're all in this together before the pandemic hit. Now everybody says that. I hate when people say that because we're not all in this together. But really,
That is true.
it's like your morale as a nurse, of course it affects me and it affects like my experience. If you're in a bad mood, that's going to affect my experience. It's a patient safety issue, right? But also what people forget about, I think, it's not only self-serving like that, but often, especially in times when I get to know you a little bit and we might come back and forth, is that I care about you as a person. And I
Right.
think we forget that us patients become very fond of people who look after us and our loved ones. Like we just do. I know we're not supposed to. And in my book, I talk a bit about like the L word about love,
Mhm.
like, and actually how really that is what the core of healthcare is, because it is about being vulnerable and having somebody look after you. And
Yeah.
if there's not love in that interaction, then that's actually a very sad thing.
Yeah. No, I hear you.
Can I read a chapter of my
Mhm.
book? Because
Absolutely, we would love that. Yeah.
I would love to hear a chapter from your book.
I still feel for you. My daughter is an RN and she works at a children's hospital too. So I've got this extra soft spot. She's only 24, right? She's just started her practice. And the fact that you're working in COVID right now, I
Yeah.
think just
Jeez.
adds like an extra layer of stress to an already stressful job, right? Like she didn't take the easy route like some of her friends did, right? She's not sitting in her cubicle. I mean, whatever. I've sat in a cubicle, so I guess I can, but it's like it's not an easy job that she's chosen. So I just anyways, this it's called All the Warm Blankets, and it just is it's like a little gift, and that I hope that your listeners it'll resonate with them. All the Warm Blankets. And at the beginning I quote my favorite poem from Raymond Carver, and it is, "And did you get what you wanted from this life? Even so, I did. And what did you want? To call myself beloved, to feel myself beloved on the earth." I remember every single act of kindness I've encountered in health settings over the past years. The images are embedded in my head like bright, glowing lights. I revisit them often to comfort me in times of distress and to rekindle hope in healthcare when my hope begins to wane. At 4 a.m., when I am dozing in the chair beside my son in the emergency room, I am grateful for the nurse who covered me up with a warm blanket. The warm blankets are my symbol for kindnesses in healthcare, and they mean the world to me. There are so many ways to share simple acts of kindnesses, even in public spaces and hospitals. I can think of the senior administrator who always lets patients and families in and out of elevators first, the nurse who lets patients or families bump in line in front of her in the coffee lineup, people who make eye contact and smile at patients in the hallway, comment on cute babies in the elevator, and hold doors open for strollers and wheelchairs. Any staff member or student who takes the time to help a lost patient or family. Even better, the staff who escort lost folks directly to their destination in the hospital. If every staff member and student committed to doing one simple act of kindness every single day for a patient or staff member in the hospital corridors and lobbies, imagine the kind of environment that would be created in what often is a rushed, stressful, and confusing place. Really, anyone working in healthcare setting, parking lot attendants, cafeteria cashiers, receptionists, clinicians, has the choices to make in every encounter with a patient a dozen times a day. Do they respond neutrally because they're hiding behind professionalism? Or do they respond with cruelness to assert their power over vulnerable patients? Or do they respond as a healer with demonstrated compassion for those people they signed up to serve? Demonstrated compassion translates into acts of kindness. One day, the occupational therapist who supported Aaron when he was a toddler looked me in the eye and unexpectedly said, "You're doing a great job as Aaron's mom." I responded to her sentiment by bursting into grateful tears. Then there was the OR nurse who ushered me out the door after Aaron was anesthetized for surgery. She put her hand on my shoulder and said, "Don't worry, we'll take very good care of him for you." A mammogram tech stroked my arm while I was administered the sharp freezing of my breast biopsy. Later, she tenderly brushed my hair when it fell into my face, causing instant tears to well up in my eyes and slowly drip on to the green hospital pillow. Our family doctor once called me out of the blue just to see how Aaron was doing when he was going through a rough spell. This seems like a little thing, but it was a big thing to me. When Aaron was hospitalized with pneumonia, he was lucky enough to have an exceptional student nurse assigned to his care. She joked with him, high-fived him, and patiently sat with him on his bed while he took his inhaler meds. I later took the time to write a thank you note to her and sent a copy to her instructor. Even if the system doesn't reward kindnesses, it doesn't mean we can't recognize and acknowledge tender care. During Aaron's hospital stay, the pediatric resident wrote his name on the whiteboard in the room so we wouldn't feel foolish if we forgot his name. A child life volunteer took the time to gown up to come into Aaron's isolation room to fix his video console. An aide stayed with my sleeping boy early one morning so I could run down to get a desperately needed cup of coffee. The nurse on night shift tiptoed about with a flashlight, minimizing disturbances while making rounds. None of this is counted by hospital funders, but all of it matters to me. A kind manner often does not take more time, and it's also free. This is my call to the return of the old-fashioned notion of bedside manner. The simple stuff matters every single time. Kindness is not about being nice. It is a demonstration of compassion that is at the core of patient and family-centered care. We are all softened by compassion. It rubs out the hard edges in this messed up, beautiful world. Give us your kindnesses in any form they take. They are a salve for my wounds, if even for a moment.
So beautiful. Like, I think I needed that today.
I don't even know what to say. I just love every word of that. I think you have a real gift as a writer, and I definitely think you're more than half a nurse, as you refer to yourself in the book. I think you have a lot of insight, and I'm just so amazed by what you've written.
Well, thank you for having me on your show. This is patient engagement at its best. See? It wasn't that bad. It was actually a little bit of fun.
Sue, where can people find you or look for your books or any of the other great work that you do?
I'd say the main place is my website. So it's at Sue Robbins with one B, like the bird.com. And so you can buy my book on Amazon. And I've also created, it's called Little Bird. It's course content for actually nursing faculties have started to pick it up, which I'm so thrilled
Oh,
about,
okay.
where they're teaching about patient and family centered care. I have some folks at Mount Royal College in Calgary and then University of Minnesota. They actually
Oh,
have my book for required reading. So I took some of the lessons in my book and made some it's free course content. So you can get at it through my website as well. And I also write essays. I've been writing about COVID a bit lately, but gosh, it's been hard to write. I tell you, like you really need the space in your head, right? We're all in a hard time right now.
for sure. Well, thank you so, so very much. And I mean, the compassion that you've even shown us has been tremendous. And I think we will continue to learn and try to be better caregivers from the exceptional information that you've shared with us today. So thank you so much.